respiratory products. Tonight's webinar is entitled Presbyphagia, Using Evidence to Guide Clinical Practice. And it is my pleasure to welcome today's speaker, Dr. Luis Riquelme, who is an associate professor and director of the Dysphagia Certificate Program at Universidad Católica del Uruguay, the consulting director of rehabilitation and speech pathology at Maimonides Health, and adjunct professor at Teachers College, Columbia University. He also co-chairs ITSE, serves on ASHA's Healthcare Economics Committee, and has received numerous honors. Thank you everyone for joining us today. We will ask that you kindly hold your questions until the Q&A session at the end. And Dr. Riquelme, I will give you the floor.
Well, thank you very, very much, Jenny, for that very kind introduction. I also want to thank Aspire for the invitation to be here with everyone today. It's a topic that is very near and dear. It's an area of interest for sure. And I guess as I'm aging, I'm also realizing that there certainly are changes in swallowing that take place. So hopefully everyone else will agree. We'll enjoy this presentation, and certainly do place your questions, I guess, in the chat section. Jenny will be monitoring those. We'll have some time at the end for the Q&A session. Here are my disclosures. And the learner outcomes, which you have seen in the advertisements. And so let's get going. So I think it's an interesting piece to start with is, who's monitoring, or how do we really know that the aging population is growing? And we've been hearing at least for 15 years now that the aging population, people over 65, are the fastest growing age group. And that's been going on globally. And this map I'll share with you from the World Health Organization shows in navy blue countries where 30% of more of their population are 60 years or older. The turquoise, we'll say it's turquoise blue, is countries where 10 to 30% of the population are 60 years or older. So I want you to see how this progresses as years go on, and look how the world changes, right? Look at Canada up there, right? We see this, then we start seeing Chile in South America, right? So really relevant to start paying attention globally. It's not just for those in the US, but I mean, look at the Americas. All of the Americas are in turquoise or navy blue. And this is, the importance here is really related to what are we doing as healthcare professionals to provide services to folks over 60 or 65, and I'll say something to that in a second, that are aging but are healthy. Right. And so, and what do we classify as healthy, right? So the 60 to 65 dilemma is interesting. The World Health Organization uses 60. Many countries use 60 as the time where, you're considered elderly. And yet we also see 65, which in the United States is related to legal practice, basically Social Security. And so in research, we see a lot of 65, but you still run into some researchers that are using 60 as a cutoff. Although globally, there's also talk about we really should be looking at 70 because so much more of the population over 60 or 65 are still quite healthy. Then, so we have this term presbyphagia, and the problem with the term presbyphagia is that it sounds like it's it's a diagnosis and something is wrong. Or that's how many people, capture it. It's not just the swallowing of the presby, the older person, right? So, but in general, these are just characteristic changes in the swallowing mechanism, and otherwise, as I said, healthy folks. Um, we do know that older adults are more vulnerable, right, to disease and to acute illnesses, use more medications, et cetera, than the rest of the population. So start putting that picture together. What's also interesting is that in geriatric medicine, we often hear about presbyphagia or a mild difficulty swallowing being the second most commonly reported symptom. Interesting, right? And it's probably followed by, the knee pain. But and this incidence data in acute care and long-term care varies by who you read, as you know. I think we also need to understand that we don't all agree on what dysphagia is, right? Do we have a definition for dysphagia? And you say, hey, it's a swallowing disorder. Okay, so what's a swallowing disorder, right? What's wrong? When we are reading, we're looking for evidence and we're reading the research out there, it's really important that we also understand what definition the authors are using for defining dysphagia. The other interesting piece is that we don't have much information on the incidence of dysphagia, for example, in other populations, in adults with intellectual disability, with intellectual disabilities. Why do I mention this population? Because adults with intellectual disabilities are also living longer, right? We were not used to seeing, let's say, a 68-year-old with Down syndrome, right? Now, that's not uncommon. Okay, so one thing doesn't separate from the other, right? Um, Another example is thinking about how to recognize the difficulty, right, before it worsens, is, the adult that shows up with some complaints of some difficulty breathing, a chest x-ray is performed, they say, yeah, there's some microcongestion, they go on antibiotics, and then just go along. That doesn't necessarily turn into a referral to see a speech pathologist and do a full swallowing workup. So we still have a long way to go in the identification of the swallowing difficulties or swallowing changes that go on with healthy aging. And then I'll share something with you a little later. The other term that we need to keep in mind in this context is sarcopenia, right? So back in the 90s, in the physical therapy literature, there was talk about sarcopenia, right? So basically, muscle changes, muscle loss, muscle mass changes in the skeletal muscles. And of course, physical therapy, they were talking about arms and legs. And it was several different groups, but one of the groups that I'll mention is Joanne Robbins' group back in the 90s, looking at sarcopenia, and that's when they started looking at the tongue, right? And so we have a lot of information now from many different labs about the tongue and tongue changes with aging and the response the tongue has to exercise. Um, but we really focused a lot on the tongue. And so be on the lookout. I have a little more information for you as we move forward. I really just wanted to set the stage here with this typical swallow because as we think about aging, it puts in question as to what a typical swallow then looks like, right? Where does the bolus head have to be in order to trigger that pharyngeal swallow, for example? When is it atypical, etc.? So if we start thinking then in that context of, when do we start calling it something not typical? then we have to start thinking about what are the consequences, right? And when we think about dysphagia, we think about safety, so penetration or aspiration, and we think about efficiency, so usually residue or discoordination. And so, but really, we should also be looking at what happens, what are the outcomes of these difficulties. And the outcomes are, usually dehydration, malnutrition, and how that impacts. The other aspect that we don't talk a lot about is that social aspect of eating, of enjoying food and enjoying the pleasures of taste, temperature, the texture of the foods that we are enjoying. So when we think about safety, we often, and as clinicians, we get a little crazy with this concern about silent aspiration, and as well we should be. I'm not saying we shouldn't be, but sometimes that takes over our thinking about our patient. We're just concerned about, oh, they might be silently aspirating. Well, there are ways for us to find out what might be going on, right? And then we also should not forget the aspects of efficiency. And does an inefficient swallow, let's say, increase the risk of an aspiration event, right? Um, I think we should be embarrassed in the United States that we still have, major concerns in managing aspiration, in preventing recurrent aspiration and aspiration pneumonias. So we really need to think about, I mean, there's the medical challenge of treating the pneumonia, but what about our challenge? We need to help prevent that pneumonia. We need to find out if it is aspiration, when is it happening? Why is it happening? Is it happening, like I said, when, before, during, or after the swallow? Too many people are just happy saying, oh, he aspirated thin liquids. Okay, but that doesn't tell me anything. I can't help somebody with that information, right? I need to know when it happened so that I can figure out now, in terms of the biomechanics, how can I help this person do better? And prevent those aspiration episodes that lead to the aspiration pneumonia. I will share, and you can figure out because I'm old, that when I started practicing, when we read a chest X-ray report, we only looked for infiltrates, and usually infiltrates in lower lobes. So, but now, honestly, any congestion, atelectasis, any interstitial changes, those are of concern, and mostly because they're going to impact respiration, right? And so, as somebody that specializes in swallowing, we should be thinking then, oh, if respiration is affected, then what's that, swallow apnea period going to be like, right? Can the person really coordinate swallowing and breathing, right? Um, this is just to highlight that nobody cares about the difference between aspiration or laryngeal penetration. Only we as speech language pathologists care, and we should, and we definitely should, but nobody else cares, right? You mentioned, oh, but the patient was penetrating versus aspirating, you know, ENT, gastroenterology, neurology, our other colleagues, they don't, they're like, whatever, you just figure out what we're going to do about this. Um, but it's important, and every opportunity I have, I try to share this information because I think we make clinical decisions that sometimes are inappropriate because we don't always have all the evidence. And look at this. This is from Robbins 99. This is from 1999. So this is really old stuff where already back then we were being told that in the age group 63 to 84, right? In this study, they found that laryngeal penetration for thin liquids and semi-solids um, occurred in 16.5% of the swallows. So are we providing enough trials during our instrumental examinations? And are we then counting and figuring out, if the patient penetrated once or twice versus they penetrated over 50% of the trials, right? So 16.5% of the swallows presented with laryngeal penetration. This was healthy adults, right? Um, They also found that laryngeal penetration was more likely to happen on the first swallow of any condition or consistency. Of course, this was video fluoroscopy, so the flavor of barium is not the most exciting thing in the world. Now, if you use Varibar, of course, there's the apple flavor, but it's still not something you might be expecting during an exam, right? A radiological exam. And then Daggett in 2006 also showed that in folks under 50, 7.4% of those swallows presented with laryngeal penetration, and confirmed what we knew since 99, that in folks over 50, about 16.8% of those swallows. That means don't make a diagnosis with just one trial. It also means don't just provide a few trials and say this is what's going on. I will share with you, and there is data available now, very recent data from Dr. Katrina Steele's laboratory that is indicating that there's a lot of information we can gather from 4 thin liquid swallow trials on video fluoroscopy. So do look out for Dr. Steele's information and papers out there because this is in the context of aspect, which is the evaluation protocol that she and her team have developed in their lab in Toronto. So watch out for that. I'm sharing this very old information with you. I mean, 1998, because this is still, I mean, this paper is still like something that if I say to you and I find out you, practice in dysphagia and I say Langmore 1998 and you don't know this paper, I'm gonna stereotype you and say some things about you because I think anyone practicing in the area of dysphagia should read this paper. This is when we started really separating aspiration as an event from aspiration pneumonia. I think also this incredible research and publication also made us aware of all these different aspects and contributors to, aspiration, things that you say, oh, yes, I know that. Yeah, but where did you find that out from? And there were things that we questioned that we were not really clear on. And things have evolved, right? For example, this reduced volitional cough is something that back in 98, we would say, no, well, I really need to be thinking about the reflexive cough, and this doesn't give me a lot of information. And now, as you know, we have, labs like Dr. Troche's lab at Teachers College of Columbia and several other labs looking at cough, looking at developing protocols for treating cough to help reduce aspiration events, right? So we have evolved, and luckily our science has evolved. But this paper also then brings us to what predicts aspiration pneumonia. And we have, again, some of the things here that we knew, but this paper also helped us start focusing on, okay, let's talk about feeding tubes, nasogastric versus gastric. What are the contributors here? There were clinicians that wouldn't evaluate swallowing on persons that were either on mechanical ventilation or had trach tubes in place. Hopefully, we're not seeing that too often anymore, but also brought our attention to things like feeding dependence, right? When was the last time as an adult somebody fed you? And so think about it. Have somebody that you trust. And I say that for a reason because there's a lot of trust involved here if you're going to allow somebody to feed you and figure out how are you cueing them that you're ready for the next trial. How do you cue them that that's enough, right? When you're drinking a liquid or when you're removing food from a spoon or a fork. So lots to think about that. Again, this paper, oral hygiene. right? Lots of things that this paper brought to our attention. Oral hygiene, we have tons of data out there supporting that. Many of us are involved, along with nursing, at many of our facilities in trying to develop protocols and programs to improve oral hygiene because we know that poor oral hygiene, poor dental status, xerostomia, increase the colonization of oral bacteria. And so, and the person might develop, a person that's NPO might develop aspiration pneumonia just from that colonized bacteria. The other point I'll make here is I still love this paper from Barbara Quinn, who's a nurse in Southern California, published in 2014, where she worked with her team hospital-wide and they reduced pneumonia rates by 38%. And she was really concerned about the mortality rates related to pneumonia at her hospital. So lots to think about in terms of putting this overall picture together. So the reality is, right? So we have the older person that's healthy. They're starting to maybe have a little trouble with pills, or they're having a little throat clearing when they're drinking their coffee in the morning. And so how can we collaborate, right, with some of the other disciplines that we typically do to really start looking at, addressing the whole patient, well, pulmonary status, overall health, dental status, um, and are they eating enough? And if they're not eating enough, why not? So, and I'll bring up a few other factors in a few minutes. So when we're then looking at the elderly swallow, um, I kind of should think about another term for that because, I'm qualifying there now, and so I need to be careful with what I write. But anyway, so we know there are some natural changes that happen, right? I mentioned with sarcopenia, we learned a lot about the tongue, and around 2015 onward, Dr. Sonia Molfenter in her lab at New York University have been doing some really incredible work looking at the pharyngeal musculature, right? And I'll just start by saying that, and she's been working with healthy older adults. Um, I'll start by saying that how fascinating to look at sarcopenia in the pharynx, right? And so we think about, okay, pharyngeal constriction, right? It happens, brings the bolus inferiorly into the esophagus. Sounds great. But in healthy aging, if sarcopenia is impacting that musculature, what happens to the work involved? What happens to that constriction? Well, it turns out that in a study that involved MRIs and lots of other analyses, the team discovered that the lumen, right, the inside space of the pharynx was larger, increased as we aged, which makes sense because now the muscle bulk, right, the muscle mass is being reduced. Therefore, there's now more open space. But what does that mean to somebody that's healthy? It means that to contract the pharynx, they need to work harder to get to midline, right? Because now there's more space to cover, right? To then squeeze that bolus and pull it inferiorly. So, and I know the work that they're doing now is also looking at then, are there some prophylactic exercises that we could prescribe or recommend to our patients to maintain tone, to increase mass, etc., just like we might do with the tongue, right? So be on the lookout for Dr. Sonia Molfenter and her lab's great work. I mentioned Dr. Steele and her lab in Toronto here in the context of declining tongue strength as we age, but also looking at some of these different parameters that we use during our assessment. We also know from Dr. Namasivaya McDonald and others about the changes in timing in healthy aging that we need to think about, right? Swallow reaction times, where do we trigger, where's the swallow to be triggered, right? When it leaves the oral cavity, when the head of the bolus is leaving the oral cavity. So those reaction times, right? And we say, okay, in somebody over 50, we have an idea that maybe by the time the head of the bolus reaches the vallecula, that's where the swallow will trigger. Well, what if it doesn't? And you see overflow over to the piriform sinuses along the aryepiglottic folds. Is that still normal? Are we now concerned? Right? So that's where we start putting that in context of, well, are there any respiratory concerns? Are there other problems? Um, so something to also consider: pharyngeal delay times, the UES opening duration is longer. Again, swallow apnea is longer. We've known that for a while. More residue, we've known that for a while as well. And what I mentioned about penetration. So it's that concept of when and so when is this a concern, right? When is this a concern? So in 2019, Dr. Namasavaya McDonald and I published this paper, really kind of reviewing this whole um, I guess in 2019 was more a dilemma. Now it's more a challenge. I think so, at least. And one of the things that we propose in this paper is, can we start looking at presbyphagia and dysphagia as a continuum? So presbyphagia over here, dysphagia over here. So somebody presents with presbyphagia, right? Normal changes in their swallowing compared to what we think is typical. But they're functional. They're doing okay. There's no sequelae to their swallowing changes, etc. So now let's say that might progress a little bit, etc. along this continuum. But now um, let's say they have a urinary tract infection or they have a really bad cold. All these compensations they've been doing, right, now break down. And so now they might enter, right, along this continuum, they might enter the area of dysphagia. But have we ever thought about the fact that dysphagia could be temporary, right? And so what we need to do during that period where this otherwise healthy person that now is just acutely ill presents with dysphagia, how do we help make that swallow safe and efficient, right? So think about the overall safety and then visualize, right, that at the end, once this person's medical health status improves, they'll come back to their baseline, right? And maybe they'll need a little help from some exercises or some other interventions, right? That's how I think we need to start thinking about this. And many times, we're just very, you know, we just go to the chopping board. This is what you present with, and then we sentence somebody to, let's say, a texture modified diet for the rest of their life at a really non-aggressive level. So big concern there, and there's that to me is what pushes us to keep learning and keep learning about the healthy swallow. So what we did find here, and we point out in our paper was, with the onset of new disorder, that's where this whole picture is compounded. So the dysphagia might worsen, or a progressive neurological disease, or any other change in their health status, which is what I was mentioning. The other thing we don't talk enough about, honestly, is endurance and fatigue, right? And there was a great paper by Kays et al. From the Joanne Robbins lab in Wisconsin, published back in 2010, looking at endurance. And I think we started really thinking about, what impact does a meal have on fatigue and endurance of the people that are eating, right? And so we know, right? We kind of subjectively assumed that our muscle strength, our coordination, all systems go are fine at the beginning of a meal, and that maybe they change throughout the meal, but we really didn't know a lot about it. Well, later on in 2021, Dr. Braitz and Dr. Mulfenter went ahead and took this study a little further. And I won't go into all the details, but they studied 30 healthy female adults. Um, so they divided them into 15 young and 15 old, and they're over 70 years old. Saw them for 2 sessions, 1 week apart. I would encourage you to read this. It's a great paper. But what they found here was that yes, certainly there was reduced anterior tongue pressures in the older group, right? When they looked at pre-meal versus post-meal. And the meal that was used in the 2010 study, and then Braitz and Mulfenter used again, was a bagel with peanut butter and 8 baby carrots. And so they found that yes, in the older group, there was reduced anterior, tongue pressures. They also found there were reduced saliva swallow pressures in the older group. And there are other interesting findings in this paper, but they concluded from this information that and I put it there, older adults appear to be more vulnerable to fatigue-induced changes in tongue strength, though the relation between this and functional swallowing remains unknown. And what I love about this statement is that it makes us again think about, so what is a functional swallow? Do we know what a functional swallow is? You might think, well, it's a swallow that proceeds and everything is hunky-dory. But you know that if you work with this population, you've seen patients that will say to you, oh, I have no trouble swallowing, everything is great. And yet their caregiver comes with them, right? And says, well, but we're here to see you because at mealtime, when she's drinking, she's doing a lot of, throat clearing. And lately she's been more congested than usual, blah, blah, blah. That's why we're here. But when you ask the patient, they said, no, my swallowing is fine, right? And so we also see with healthy aging that persons begin to make adjustments, right? Maybe eat softer foods, et cetera, on their own, but don't necessarily consider that a problem. They consider it functional, right? And so then we need to be careful at kind of with what questions, or design better questions to figure out what that means, because there's nothing worse than having somebody that says, my swallow is fine, and then you do your workup, your clinical exam, your instrumental exam, and you find some problems and you want to address them, and the person's like, but I have no problems, right? So I've always had an easier time counseling that person and showing them some of the difficulties we're seeing if I already know that maybe they have been presenting with some problems, but they're not recognizing them yet. Okay. So again, a few more little pieces to think about. So then I guess the next question is, how do we find out, who really is having a problem, who's not having a problem, and trying to prevent the waiting till they're admitted to the hospital with, respiratory problems, let's say, as an example. So, this basically sets up our little chart for how we manage dysphagia, right? There's a screening, and if there's no problem, you continue, everything is hunky-dory. There's a problem, you do a clinical exam that might be followed by an instrumental exam, and then you think about, rehabilitation. And that's kind of the pattern we tend to. Sometimes screening is altogether eliminated because there is a problem, and so the referral goes straight to clinical swallow evaluation. But in screening with older populations, I'll bring up two possibilities, and uh, I'll share with you that we know, and this is thanks to the work of Dr. Namasewaya McDonald. We know that self-reports are unreliable, right? That texture modified diets aren't the what really say to us, oh, this is somebody with a swallowing problem, because somebody might be on a texture modified diet for a different reason, maybe because of their dentures or whatever the reason might be, right? Um, and so maybe mealtime duration is something to be looking at. And that was one of the questions Dr. Namasiwaya McDonald had. And so in 2017 and 2018, she decided to look at this and found that in long-term care specifically, folks that were consistently taking greater than 40 minutes to eat really required a clinical swallow evaluation um, to address why it was taking them so long. And so the clinical swallowing evaluation, would be done. She's now one of the limitations that this study had was that it hadn't been validated to really look at then what were the next steps, right? But it did help identify some folks that were having difficulty that wouldn't have been identified earlier. Now, the other popular screening tool we have is the 3-ounce water swallow challenge, right? And we learned more and more and more about this. And now there's the Yale Swallow Protocol, which is more of a quick clinical assessment. But the 3-ounce water swallow challenge has really, I mean, it's become popular around the world. There are other screening approaches, right? The modified massa, the Tor Best, et cetera. But again, we should really start looking at, okay, can we start screening some of folks? Do we look at older folks that are institutionalized? But if we're thinking about healthy older folks, right? Right, because we're talking about presbyphagia, why are we screening them? There's no complaint. So that makes identification, I think, a bit more difficult, challenging, right? Do we go the route of education, right? Let's educate folks about what swallowing problems are and where to get help. And maybe that's a start, right? And so we have, some work cut out for us to educate older persons on the fact that, yes, there's help for you if you're having trouble swallowing. Just like we think about, okay, we need to educate people with Parkinson's disease more as to changes in their speech or changes in their swallowing are common in Parkinson's. So, and you can get help. Right, you have these great specialists that are going to evaluate you and support you and help you, et cetera. So can we start doing that with presbyphagia, with folks, that are aging well, and so go in that direction? So something for us to think about. Again, just limitations here with screening, as we know, about coughs can be deceiving, and also they don't really give us enough information. A screening tool is simply a yes or a no, right? They pass or they failed. That's a screening. It can't get fancier than that, or then it becomes an evaluation. And then usually, of course, again, we think about assessment, and so we're thinking about the clinical swallowing evaluation. We think about then the instrumental exam. But when do we need the instrumental exam, right? Because in somebody that's acutely ill, decompensated, malnourished, maybe this isn't the right time. Maybe let's give this person a few more days, let them benefit from, let's say, the temporary nasogastric tube that might be in place. Let's make sure it's a small French nasogastric tube so that we can still do some PO trials and prevent any muscle wasting from, not using their oropharyngeal mechanism for swallowing. And so maybe the instrumental exam will consider it in 3 days and 4 days as we see them improve. I know we have the pressure of length of stay, and that's when we also then start educating our colleagues on refer this patient to me sooner, right? Don't wait until the day before you think you're going to discharge them to figure out, oh, can we pull out the nasogastric tube and get them, eating 100% of their diet by mouth. So, we do need to educate our colleagues on when to refer to us, right? Um, so why the instrumental exam, right? Clearly, we don't have X-ray vision, right? So we need to better understand what is happening. We do know that around the world, there isn't always access to instrumental exams, right? And so we try to do the best we can with a clinical swallow exam. I think there are many risks involved, and I have been in situations where I don't have access to instrumental exams. Okay, so um, what happens there is progress is then slower, right? Because you're a bit more careful if you are managing a patient only with the clinical swallow exam. The other reality is that, for example, in institutions, let's say in nursing homes and long-term care, there are many patients we manage without an instrumental exam, with just the clinical swallow exam. We don't have a clear picture. I always had this idea. At one point, our team, some years back, we covered several nursing homes in Brooklyn and Queens, and always wanted to go back and take a look at those people we managed, and we were able to get onto, full PO diets or get some of them even get their pegs removed, etc. How we did that without an instrumental exam. What were the characteristics of that person that said to us, we don't need the instrumental? And mind you, we had access to the instrumental, right? Um, so think about that. So timing, access, and how it impacts then our service provision. Okay. The other piece is we really need to know why things are happening, right? And, if somebody says, I feel some leftover, don't just think, oh, the effortful swallow is going to be the end all. We'll fix it with that and everything is great, right? Because sometimes the effortful swallow worsens the overall biomechanics of the swallow. So do try to, go for that instrumental exam. Maybe if you're not an endoscopist, maybe a collaboration with the consulting ENT that comes in to try to do the exam together. See what resources you might have available. So then, again, we figure out, so when is it dysphagia? Well, again, I mentioned at the beginning of this talk, we don't always agree on the definition of dysphagia, right? And several colleagues have been bringing some focus groups together. Doctors Suter, Marty Brodsky, and Giselle Mann have been trying to figure out, okay, what is dysphagia? What's the definition? And we're not agreeing on the definition, folks. So remember that. We need to figure out what this functional status is. Oh, that's a functional swallow. What is a functional swallow? One that seems like it has no problems. Well, it depends on how you look at it. Or does it depend on who looks at it? Um, and then think about that continuum. Dysphagia is not static. We should not be, and I'm sorry for the strong word, but sentencing folks to a diagnosis with its accompanying limitations, unless we know that's for real, right? And maybe we need to counsel folks about the fact that this might be temporary, right? And that, there is room for improvement now, and then also counsel folks with progressive neurological disorders, let's say, where they're going to get worse, and maybe we need to, help them understand that process so that we can work with them and allow them to really maintain a good quality of life, because that's the idea. right? I think when we think about malnutrition, dehydration, swallow biomechanics, all that stuff, the bottom line is quality of life. What's going to allow this person to continue to enjoy eating, to enjoy the social aspects of eating, the sharing with family, with loved ones, okay? So now I've been gearing towards this thinking outside the box, right? And so I want to share with you a story, and I'm going to end with this, right? This was totally unsolicited, okay? Aspire did not say you need to bring in, you know, our star product into full view. But I want to share this with you because it was a great experience. I mean, right now, if we look at the evidence we have for use of the expiratory muscle strength trainer, the EMST, we find lots of research that has employed the EMST, not only in our field, but in other fields as well. But if we go back to the beginning of when the device was out, so we're talking probably 10, 20 years, um, it was originally Dr. Sapienza developed it for patients with Parkinson's, right? Initially, was the thought was voice, and then they discovered that it was also helping with swallowing. And then Dr. Michelle Troche and Dr. Karen Hegland and others have been using EMST, et cetera. But the initial bunch of research that they all did focused on patients with Parkinson's, right? And around that time, when this had just come out, one of our pulmonologists at the hospital calls me and says, "So I've got this great older man who comes to my office. He's 84 years old, he's independent, he's healthy, but he shows up with this congestion, and the chest x-rays aren't helping me figure out what's going on. I put him on antibiotics and he improves, but then he's back 4 to 6 months later, he's back with the same thing. And this is now the third time he's here with this. I'm wondering if, you could, see him and see what's going on, etc." So we did our clinical swallow exam. Cranial nerves are fine. Voice was fine. Swallow trials, he did well. Mental status was great. But we said, based on this history, let's do the video fluoroscopy, which we did. And the major item that we found was increased frequency of laryngeal penetration, right, for thin liquids. And we thought, oh, but no aspiration, right? But look at the frequency. We're talking 40%, right? And we normally would do, 3 to 6 trials. I think we did 10, and then we did the semi-solids, the rest of our exam, then we did thin liquids again. So we said, okay, interesting, but he's not aspirating. Okay, so he's got this laryngeal penetration. We see why it's happening. Do we go with these our neuromuscular exercises? What are we going to do with him to strengthen that upper airway? And then we thought, there's this EMST little gadget, right? And we have them, and let's give it a shot. And so we said that to him, right? Again, full disclosure, right? We have our ethics. Um, so this has been developed, and the research we have to date is for patients with Parkinson's. But we'd like to try it with you. What do you think? Well, let me tell you. 4 weeks, and the EMST protocol is usually 5 weeks, but at 4 weeks, we did the repeat video fluoroscopy, and look at his laryngeal penetration. It was reduced to less than 8% of liquid swallows, which, as you know from what I said before, is well within norms for folks over 50. And follow up 3 years later was the last time I asked his pulmonologist about him. No further respiratory infections that were related to this. So that's just a story to share with you about, yeah, we need to keep learning, we need to keep trying, but we need to base it on the evidence that we have and trying to pull all those pieces together. So I will end now by sharing, if you have any interest in our certificate program in dysphagia at Universidad Católica del Uruguay, here's how to reach us, hoping your Spanish is good. If you'd love to go to Cancun for a great upcoming conference in May of 2026, the Latin American Society for Dysphagia will have its fourth Congress. And thank you all for being here, and thank you to Aspire for inviting me. And I will stop sharing the screen because we want to open up for questions.
Thank you, Dr. Riquelme. That was incredible, and you gave us a lot to think about, which I think we all appreciate.
Thank
Um,
you.
we have a few questions that we will take, and then we'll wrap up. The first one is, if swallowing is a submaximal task in healthy people, do you think it then becomes a maximal task in people with sarcopenia?
Well, okay, I'm going to say yes. And I'm going to say that based on the great work that Dr. Sonia Molfenter and her team have been doing at NYU. I never really thought about it until that first study they published, right? And which was, um, oh, so as we age, we actually have to work harder to squeeze the pharynx, right? Because we have more of a distance to go. So we compensate. And that's when I started thinking, so then we compensate regularly, right? However, now if we have a cold or we're weak for some other reason, um, it's going to be harder to compensate. And that's when we get into trouble. And that's where that continuum thinking kind of goes. Yeah,
Yeah,
definitely.
so
Good
interesting.
point.
And I think a lot of us have not ever thought about it that way. Um, Question is, so if dysphagia can be temporary, how do you document that? Because it follows patients wherever they go. So how do you distinguish temporary from permanent dysphagia?
Well, I guess the the big issue is who's documenting it, um and then how do we document it, right? Because I think what I have often written is dysphagia with good prognosis for improvement, and that kind of then leads to, oh, so this person will, can get better, right?
Yeah,
So I never use that word temporary. And also we need to be careful because it's like, how do you know it's temporary? Something can happen tomorrow and now it's not
right.
temporary, but with, good prognosis. I think that would be the way to go.
That's a good lead into our next question, which is how often frequently should we be reassessing these patients for improvements in swallow when swallow function has acutely worsened and diet texture modification has been recommended?
Yeah, so that differs by population, right? In acute care, and I know we have issues with caseload and workload, but we have to be more creative, right? I mean, I'll share with you, my colleague Alexandra Soifer and I went to a new hospital about 3 years ago. Actually, I don't have to say the make-believe hospital because you know that I'm at Maimonides, right? And when we got there, the focus was evaluate, 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 evaluate. And I said, wait a minute. So you're doing an evaluation and this person is not seen again. Well, we don't have enough staff, and so we can't get to them. So then what's the point of doing these evaluations? Because you did the evaluation today, but maybe this person wasn't doing great. They were just starting on their antibiotics or their medical treatment. They might be different tomorrow. So then you're evaluating them and sentencing them to a poor outcome, right? And so I was really concerned about that. We have changed that, luckily, and that's not the case anymore. And so I think it's important in acute care. I say we need to follow daily,
Yeah.
right? Right, depending on the diagnosis. Outpatient, I think if we have them on program, we should be seeing them at least twice a week. I don't have any evidence to support that statement. Okay, I'm letting you know right now, but again, it depends on their diagnosis, the etiology, as well as why we're seeing them.
Right. And the things that we are seeing, like if they're worsening or if they look like they're better, that could lead us to then deciding when to evaluate or reevaluate.
Correct. Correct. Correct.
Can you elaborate on your
Mhm.
statement how effortful swallow can decrease biomechanical function?
Okay, so I'll be brief. There are I think there are a few studies we could look at, but two things pop up: effortful swallow and its impact on folks with history of cardiac problems, right? So it could be detrimental, believe it or not. The other thing is effortful swallow that we institute without really understanding the biomechanics could worsen the swallow. For example, somebody with lots of residue, and maybe residue that's just right at, let's say, the area epiglottic folds, right about to spill into the airway, and you ask them to do that effortful swallow, and they're just squeezing that material right into the airway.
Yeah,
Boy, I'm glad I thought about that one. That's a good question.
that is a good
But
question. I
yeah,
was like,
so
"Whoop."
we need to be careful with these maneuvers. And there's data also for concerns with the chin tuck, right?
Absolutely.
Because
Yeah.
chin tuck in some patients worsens the aspiration,
What we
the
do
volume
know
of
is
aspiration.
no blanket treatment for everyone, right?
Exactly,
We do have to do
exactly.
our jobs. Yeah. Okay, we'll do one more. Do you know of any presbyphagia video fluoroscopic studies or FEES examples that would help provide a visual to determine disorder versus presbyphagia? If you're familiar with any.
I don't think it's that black and white.
Yeah.
Um, so and I'll give you the perfect example. When we started, even before we started talking about presbyphagia and all this stuff, and I remember these conversations back in the 90s when we started talking about, oh, but now there are some people where the swallow is triggered, but the bolus already reached the vallecula. So that's a delayed swallow. That's pathological. We need to treat that. But there was nothing else wrong with the swallow, and there was there were no health characteristics that we could connect to that the person was having trouble or anything like that. So why would we say this person presents with a dysphagia when that was the only characteristic we noticed in the biomechanics? Right. Now we know. The other thing is back in the 90s, we only had information on some younger folks, usually graduate students in their 20s, right? And information from then the older folks, people over 60 and 65. Now we have more information on the in-betweens, right? And we have a lot of healthy data. So lots to think about in terms of putting that whole person together before you can say, okay, this is presbyphagia, right? Or this is, but also think presbyphagia isn't a bad thing, right? I mean, technically, if I were to do a video fluoroscopy on me, I mean, I know there are times where I'm triggering the swallow later, and the bolus is further into my pharynx. So, am I presbyphagic? Yeah, I'm old and I'm swallowing. And that's fine. And so now the question is presbyphagia a disorder? And I say no. If we think about the continuum, presbyphagia is that functional compensation that people do to maintain their quality of life. And then we have this continuum where they get to the dysphagia, and hopefully they come back.
Yeah. And I think at the end of the day, it's about maintaining that quality of life. And I know
Completely.
that is always the emphasis of your talks, and I appreciate that so much.
Thank you. Thank you. Thank you. Thank you.
We are going to wrap up for today. Thank you, everybody, for being here. If your questions were not answered, Dr. Riquelme has kindly provided his email address, which is in the chat. It is luislp@me.com. If you need a certificate for continuing education, it's for PDH, you can email me. My email is also in the chat. It is jenny@emst150.com. And we invite you to our future webinars. We have some great speakers coming up. Dr. Riquelme, thank you so much. Have a good evening.
Thank
We
you and
appreciate you.
Aspire for inviting me.
Our
Take
pleasure.
care,
Thank you.
everyone.
Have a good evening.
Bye-bye.
Bye.